Hi, welcome to chapter 14. Today we're going to talk about treatments for anxiety disorders. Fear is a negative emotion caused by a real or perceived imminent threat. Imminent means that the scary event would occur within the current time frame, like right now, soon. When there's an imminent threat, whether that threat is real or imagined, automatically our sympathetic nervous system activates and our body goes into flight or fight mode. So, if you're walking down the street and a gorilla starts charging in your direction, that emotion that most of us would experience is fear. Fear is what activates that fight or flight. Am I frozen or do I run for my life? Anxiety is a negative emotion such as worry or distress concerning potential outcomes. It's worrying about events that haven't occurred yet, like having anxiety about final exams, what your final grade is going to be, whether you will be able to find a job after college, whether your partner is going to be unfaithful, missing your flight tomorrow. Both are emotions that help keep us safe. It alerts us to potential harm and it allows us to avoid it. Anxiety disorders can be caused by the environment and by genetics. In the Diagnostic and Statistical Manual of Mental Disorders, the DSM, there are several disorders under the anxiety category. However, while OCD and PTSD are listed under anxiety disorders in this book, they are not technically anxiety disorders according to the DSM. So people with OCD and PTSD do have a high level of anxiety. They're just not categorized under anxiety disorders because they have their own category. Specific phobia is characterized as intense fear of anxiety associated with a specific object or situation, such as an animal, something in the environment, such as heights, flying, getting blood drawn, the sight of blood or needles, injection, or injury. And the fear is so significant that they will go to any length to avoid it. And the fear doesn't have to actually match up with the potential threat. And this fear causes them a significant amount of distress and impacts their daily functioning. There's actually a few more criteria in the DSM for specific phobia, but due to copyright issues, I can't list all of them. I can, however, give you some examples of what having specific phobia looks like. Jessie is a 24-year-old and terrified of needles. She would start stressing out days before her appointment to get her blood drawn. On the appointment day, as soon as she pulled up to the clinic, she started panicking, became weak, started breathing heavily, and her symptoms got even more intense when the phlebotomist brought out the needle. So I initially attempted to bribe her with a 5-course meal and this fancy restaurant if she cooperated. She's a chef, so in any other situation that would have worked. She began to have a full on panic attack, started crying, hyperventilating, and almost fainted. Then she attempted to escape out of her seat, and only then did I realize that she wasn't playing. Because at first I thought she was just, slightly terrified of needles. No, this was a full on panic attack. I had to coach her through deep breathing exercises, and 45 minutes later, the tech was able to get the blood. Jessie was still pretty shaken up until about a couple of hours after. I'll use myself for the next example. So I am absolutely terrified of heights. It's like my amygdala, the fight or flight part of the brain, is super dramatic. So anytime I'm looking straight down from anywhere higher than a second floor building, I get dizzy. So at shopping malls on the second floor, the barriers are made of glass so that you can see directly to the first floor. So instead of like a wall that goes around the second floor, it's glass. They want you to be able to see. Anytime I walk too close to that glass, my hands get numb or my stomach turns like I just went down a roller coaster. But I also love riding on roller coasters and flying. I always like to look out the window or look down when I'm going up on a roller coaster. So one year, my friend convinced me to walk the Brooklyn Bridge. I walked it, but the entire time my legs were like weak. My hands got numb quite a bit, and my stomach kept turning, especially when I walked too close to the edge. This was also at nighttime. So the whole time I tried to distract myself, asking everyone I passed by whether they needed me to help them take pictures of them. And, I also distracted myself by taking pictures of the scenery. It didn't help that the floor was made of wood and there were big gaps in between, so you can actually see the cars passing under you. Yeah, that definitely didn't help. So I was fine as soon as I got to the end of the bridge. I continued to walk like there was nothing wrong with me. After hearing about these two scenarios, do either or both of these sound like phobias? Why or why not? Think about it a bit before looking at the answers on the last slide. Okay? To prevent you from seeing the answers accidentally, when you view the last slide, it's going to look blank. What you're going to do is you're going to click, you're going to highlight this, and then just change the font to a darker font, and then you'll be able to see the answer. Panic disorders. A panic attack is abrupt and can be unexpected with strong physiological reaction that is accompanied by intense apprehension or terror. This would present as heart palpitations, sweating, breathing, short and labored breath, feeling like nothing is real around you, fear of losing control, fear of dying, and more. Panic attacks can actually occur at any time, whether out in public, in private, during a specific threat. That when someone has multiple panic attacks and have intense fear that they will have a panic attack, they would then be diagnosed with panic disorder. So now you might be thinking, how is panic disorder different from specific phobia? Because some of these panic symptoms are like what Jesse had, right? Someone who has panic disorder would have many panic attacks, but those panic attacks may not be associated with anything. This person may have a panic attack taking a walk, eating dinner with family, taking a shower, at a party, at any time. So basically, if there is another diagnosis that better explains why the person is having those panic attacks or symptoms, it would be something other than panic disorder. There's a lot more to anxiety disorders. They also overlap, which make them kind of confusing. I don't need you guys to be experts. Just know that each are categorized a little bit differently, how they are different based on what I've given you. These two videos should help with your understanding of panic a little bit more. Agoraphobia is described as profound fear of being in a situation where escape is difficult or embarrassing, especially if panic occurs. This person's going to have a significant amount of fear associated with at least two of these categories. Being trapped in an enclosed space, like a roller coaster seat, elevator. So they will only take the stairs, and if the stairs are not doable, they just won't enter the building, period. Being outside alone without anyone, open spaces like the ocean or desert, being on transportation, riding in a car or bus. More so on public transportation, less so in a car. Car is a little bit easier to escape from. Someone with agoraphobia will perceive these situations to be too difficult to get out of, too embarrassing to try to get out of, because they might have a panic attack when they're trying to get out of it. So, how is this different from specific phobia? Remember, all of the disorders we're talking about today all fall under the anxiety category, so they're going to overlap a little. With specific phobia, the individual is fearful of a specific stimulus, and with agoraphobia, the person would be fearful of two or more situations, so it's a little broader than specific phobia. Now, Jessie is fearful of the needle, seeing blood, getting her blood drawn, so she's going to avoid the clinic, but she's not going to avoid the clinic because she's afraid that she can't escape. She's avoiding the clinic because she's afraid of all those other things. Let's throw James in the mix. James, on the other hand, is fearful of going to the clinic because he thinks that if he has a panic attack, he's not going to be able to escape out of the clinic. James may also not go to a movie theater because if he started to have a panic attack, he wouldn't be able to just run out. There's a lot of obstacles. Having a panic attack in front of other people would also be extremely embarrassing. So that would be his fear. He's not afraid of the movie theater, he's afraid of not being able to escape the movie theater. If he was afraid of the movie theater, like going to the movie theater alone makes him want to pass out, then maybe it's a specific phobia. Thinking about the movie theater gives him anxiety. That kind of overlaps with agoraphobia because, yes, if he's afraid he's going to have a panic attack in the movie theater, he's going to be afraid of the movie theater. He's not going to go. Right? But that's very broad because it wouldn't just be the movie theater, it would also be other places that have a lot of people that is not easy to get out of. So, again, that wouldn't be specific phobia because it's broader. He's just afraid of enclosed spaces. Social anxiety disorders associated with an intense fear of social or public situations because of the fear of judgment. The difference between agoraphobia and social anxiety disorder is that someone with agoraphobia has a fear that they can't escape the situation or place, so they will avoid that situation or place. Someone with social anxiety disorder will avoid certain situations because they're afraid that they're going to be judged. They're not afraid that they can escape. Of course, they do wish that they can escape when they feel like they're being judged, but their main concern is people judging them. So James might be avoidant of the movie theaters because of fear that he may not be able to get out when he's having a panic attack. And Jack might avoid the movie theater because he's afraid of being judged by the people inside the movie theater while he's walking up the stairs to get a seat. Someone with generalized anxiety disorder has chronic excessive worries about events, individuals, activities, almost every day for at least 6 months. And this person will have a really hard time controlling their worrying. This person is always going to be worried and always going to be exhausted because the worrying takes a lot out of the body. So we all have worries, right? We worry about how we'll do on exams, if we'll wake up late in the morning after a long night, spending over budget, the well-being of others. The average person wouldn't worry about all these things with the same intensity, right? These are also typical things that we worried about from day to day, but we can usually work this worry out and still continue with our days. So we might worry like, oh, I hope my blah 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 gets home safely, or I gotta set 2 or 3 alarms because I'm worried that I might not wake up, but that's not going to consume us. Someone with JD may worry about all of the above but won't be able to stop that worrying. So eventually what happens is that worrying starts affecting their job. It consumes them. It affects their schoolwork because the things that they're worried about are taking up all their energy, time, and concentration, and they're not able to do anything else. So, not being able to focus on work or forgetting to do things at work because their brain is incapacitated by that worry. Obsessive compulsive disorder is distress that comes from obsessions accompanied by compulsive behavior aimed at reducing stress. Obsessions are thoughts that occur repeatedly, and compulsions would be the repetitive physical or mental behaviors that are performed as a result of the obsessions. Ollie has a fear of contamination. If he touches something in public, he'll likely stress over the fact that his hand is now contaminated. That's the obsessive part. This leads to him washing his hands repeatedly to get rid of the germs, but the obsessive thoughts won't go away. So he keeps washing his hands until they do. Even if it means he's going to be late for work or late for school, or even if he may potentially rub his hands raw, he will continue doing it until that feeling subsides. And then we have Lulu, who has obsessions with things being lined up perfectly, and if they aren't, she will organize them until they are perfect and or to her liking. Compulsions are so intense that even if she's late for school or loses friends, she'll attempt to continue doing what she's doing, and or if she does have to stop, it really impacts her emotionally, and it's going to be hard for her to regulate. She's going to be thinking about this throughout the entire day. Like, people often say that they have OCD because they like things organized or tidy. The difference between them and somebody with actual OCD is that the obsessions and compulsions are extremely difficult to stop. Jane likes her kitchen clean and organized, And if her roommate doesn't put things back where they belong, Jane gets very angry, very irritated, but can still move on with her day. Okay, she might be mad throughout the day, but she's going to get through it. She still can complete tasks that are necessary. Lulu doesn't necessarily need her kitchen to be organized, but certain things have to line up. Let's say seasoning bottles. If for some reason she had to leave the house with those things out of place, she may think about them all day and feel very irritable and anxious about them not being in place and have a hard time concentrating in class because of those obsessive thoughts. Rather than self regulating by thinking, I'll get to them as soon as I get home, she'll obsess over them not being able to do it right now, because if she doesn't do it right now, serious consequences are going to happen. While OCD isn't exactly an anxiety disorder, OCD is anxiety driven. PTSD is also not an anxiety disorder. PTSD can be caused by experiencing a traumatic event personally or witnessing or knowing someone close who experienced a traumatic event. So this person would have intrusive thoughts, flashbacks of the event. They would avoid anything that reminds them of the traumatic event. Their mood and thinking would be negatively impacted, and like with almost every disorder we talked about, work, school, or social life will be impacted because of the symptoms. So if a bank teller gets robbed and she starts having flashbacks of the events and then starts being afraid of going to work, which is avoidance, her cognition is distorted because she thinks anyone wearing dark clothes with a mask could be the robber because that's what he had on. She may also think that she's going to get robbed again. So she might have trouble going to sleep, be sensitive to sudden movements or people talking too loud. And all of these symptoms occupy her thoughts so much that she can't go back to work. The first day she tried, when a customer walked up to her window, she initially froze and then ran to the bathroom crying. So sometimes these symptoms are not as noticeable because they occur inside the head, but they are equally as distressful. Based on what this bank teller is experiencing, would you think that she had PTSD? There's a link here with the full DSM criteria. Again, I can't list them because I didn't get permission to, but this website probably got permission from the APA. Increased activity in the amygdala is associated with fear, anxiety, and aggression. Those who have anxiety disorders and PTSD have dysfunction in the amygdala, but for those with OCD, there's less notable problems. However, there are atypical functioning in several other areas of the brain. So, how does information get to the amygdala? Let's review a few items before moving on. We're going to look at this diagram real quick. Say the amygdala, you already know. The thalamus, which is here, is the sensory allocator. The hippocampus, like the memory center. Hypothalamus excretes hormones and neurotransmitters. This is the prefrontal cortex. It's responsible for decision making. This is like where the adulting happens. The thalamus is a relay center. Any stimulus that we hear, touch, see, or taste is received by the thalamus and is sent to the different parts of the brain to be processed. There are two pathways that information gets sent to the amygdala. The thalamo-amygdala pathway, which is the short route, and the thalamocortical pathway, which is the longer route. The difference between the two pathways is basically reacting immediately to that stimulus without much thought, or processing what that stimulus is and reacting accordingly. So one's immediate and one's a little bit longer. They both happen within seconds, but one has more cognitive component. I'll give an example of the long route first. So most of us have experienced or have heard about fireworks or firecrackers during certain holidays like 4th of July or Chinese New Year. And you know that if you're too close to things that are going off so loudly, it can be deafening. So this information is in the back of our heads. We're not actively thinking about it, right? If we're at home alone and hear a loud banging or cracking outside the door, the auditory sensory signal goes through our ears and then it goes to the hypothalamus and to the hippocampus. Okay, the thalamus relays that information to the prefrontal cortex, and then that information gets processed. So, and at the same time, the hippocampus goes to work. Its job is to provide some kind of context to what that sound might be. It says, like, oh, yeah, I remember hearing that similar sound during Chinese New Year. That sound is likely firecrackers. So the prefrontal cortex then is like, oh, okay, I'm safe then. No need to react. Let's just peek outside just to make sure. So the original sensory signal is weakened through this process. It's like the hippocampus pulled out all the facts that it knew about that sound. That informed the prefrontal cortex on how to proceed. The prefrontal cortex did some adulting, made some decisions, which diffused that initial loud noise. So by the time that signal reached the amygdala, it wasn't that loud anymore. So the amygdala didn't have to cause too much of a ruckus. Now that the distress signal reached the amygdala then sends signals to the hypothalamus and a couple of other parts of the brain. Stress hormones are released, and our body physically reacts. Since this wasn't too much of a threat, our body is not as tense and heartbeat is likely slowed significantly. Or the hippocampus might tell us that those were not fireworks, those are gunshots. It's November and there's no celebration happening, and at this hour. Prefrontal cortex says, okay, we need to do something, makes the decision. At that same time, the amygdala and hypothalamus send strong signals to the locus coeruleus and adrenal glands, activate the release of adrenaline, and boom, sympathetic nervous system is activated. Adrenaline then increases in our heart. More oxygen can be reached to our muscles, and this is what helps us prepare for fight mode. So with the long route, there is some background information being retrieved, information is getting processed, so there is some time to think about how to respond, even if it's only a few seconds of time. The process is actually a little bit more complex, but you get the idea. With the short route, the thalamo-amygdala pathway, notice that there's a difference in this name. The word cortical is missing. This should tell you that there's steps missing from this pathway. Let's say you're leaving the store and you hear a series of loud bangs in the full parking lot. You don't see anything, you just hear bangs. Instincts kick in right away and you probably duck. Maybe you run in the store, maybe you hide behind someone or something. Or if your car is close enough, you might run to your car, right? Or maybe you freeze. With any of those responses, was there processing involved? Did your actions demonstrate that you had time to think about what that sound was? Like, if you hear a loud sound and you duck, did you think during that time? No, it was automatic. Your body was almost like trained to respond to that loud noise. If you lived in LA long enough, you might have heard plenty of gunshots or know what a gun sounds like. So there's not much to process before you react. So that loud noise that entered your ear, that signal made its way to the thalamus. The thalamus then sent that signal straight to the amygdala. Brain was like, nope, not positive what that is, but I'm not sticking around to find out. So there was no processing. Brain was just like, sound, duck. That's the short route. The long route, brain was like, what could that be? Had time to think, had a cup of coffee, then decided, okay, no need for alarm, or at least had some time to think about it and what the best course of action would be. Okay, so I'm exaggerating. The entire process happens within seconds, but compared to the short route, brain is like totally different. Here's a video of what our bodies look like when we are experiencing this entire stress response. The link is also on Canvas under the chapter slide, so this way you don't have to re-download this slide, okay? When someone experiences a panic attack, the amygdala and hypothalamus send out distress signal. The sympathetic nervous system gets to work, hormones are released, muscles constrict, heart rate increases, and so on. Of course, symptoms will vary from each experience and from person to person, but ultimately the physiological response that our body experiences in a panic attack is the same as the response we had to those gunshots. The only difference between the two scenarios, panic attack and actual threat, is how we interpret that information. How do we interpret that situation? And what resources do we have to decrease that distress? The general adaptation syndrome is a process that the body goes through when it experiences distress. This starts with something happening to us that we interpret to be significant, whether it's positive or negative. Say Jack's at a stop and in his car, and he gets rear-ended by a car that was going 45 miles an hour. The first stage is the alarm stage. Stress or fear is experienced. Sympathetic nervous system activates, so body is in fight or flight mode. The second stage is resistance. This is the body maintaining the physiological arousal due to that ongoing distress. The structure responsible for this stage is the HPA axis, which I will talk about a little bit more in a minute. Jack is still in shock in this stage. Body is tense, he's shaky, and he feels like he's had too much caffeine. This is because during that stage, the hypothalamus releases corticotropin, which influences the pituitary to release ACTH, which then influences the adrenal gland to release cortisol. Since our bodies can only handle being in a state of distress for so long, it eventually becomes exhausted. So in the third stage, Jack is going to feel fatigued, though he might still be anxious and continues to think about the accident, afraid that he's going to get into more accidents. And he's also depressed because he no longer has his transportation. He no longer feels safe either. So in this stage, Jack has really had a hard time coping with the stress, which is what led to the anxiety and depression. For those of you who don't have physical disabilities, arthritis, or any other pain in your hands and arms, try clenching your fists really tight and hold it for at least 30 seconds. So pause me and then come back. This is what level 2 resistance stage is like on a small scale. So after clenching for so long, your muscles are probably tense and remain a little crampy for a while, which is what stage 3 is like. This is where the meds come in. Sedatives are a category that causes calming effects. These include barbiturates and meprobamate. They're not used as much anymore because they have really bad side effects compared to the other meds, and there are just other meds that are more effective that have taken their place. Benzos are a safer choice. They include Valium and Xanax and a bunch of others. They can take effect within minutes to an hour, so it's effective for somebody with panic attacks or have high levels of anxiety that need to be addressed at like crucial moments. So benzodiazepines might be appropriate for somebody who has chronic social anxiety, but often has to speak in front of 15 people or more for work. That person would need calming before giving speeches because he might hyperventilate and pass out if he doesn't, right? Benzos do come with risk of addiction, especially those who drink moderately or use other substances. And it's also really convenient. The convenience aspect of it does make it a higher risk. Buspirone takes about 2 to 4 weeks to start working. This might be more effective for somebody with generalized anxiety disorder. Skipping to slide 30. In addition to the traditional anxiety medications, antidepressants such as SSRIs, SNRIs have become well used to treat anxiety in the more recent years. SSRIs and SNRIs prevent serotonin reuptake, which means that more remain in the synapse. And remember, the synapse is where the magic happens. Here's a comparison chart. You can look on your own. There's also MDMA, which includes psychotherapy. While there are ongoing trials, MDMA is still Schedule 1, so the only place it can be used to treat PTSD is in a clinical trial. Okay, there are many numerous trials that have gone on, and these trials have shown that MDMA with therapy is actually pretty effective for treating PTSD. However, since it is still Schedule 1, it's not obtainable and hasn't been approved officially to be on the market. When it does, it will likely not to be on Schedule 1. It would probably be on like 2 or 3. Basically not be illegal because it would then have therapeutic effects, proven therapeutic effects. As with almost all mental disorders, if drugs are necessary, they should always be paired with psychotherapy. Taking drugs for mental disorders, like riding a bike with the training wheels, it can be helpful to start off slow, but if you forever ride that bike with the training wheels on, you're never going to learn how to steer or become independent. There are always going to be limitations, and you can't go as fast, right? Psychotherapy is like practicing writing without the training wheels. You start to develop that muscle memory and you start to gain confidence, and you're not limited to writing a specific speed anymore. So, in therapy, if somebody has chronic anxiety and they can't sit long enough or keep their mind from wandering long enough to do the work in therapy, therapy is pointless. So then this person may need some anxiolytics or benzodiazepines to calm them long enough to do the work with a therapist, and or you know to learn the skills effectively. Once they learn the coping strategies, reframing maladaptive thoughts, and develop more adaptive behaviors, they're able to use those skills to bring that anxiety down and can slowly wean off the meds. So after mastering these new strategies, they become second nature, and the person learns to think more adaptively automatically. So their initial response is not going to be anxiety. Their initial response might start off being, okay, how do I fix this problem? Let me reframe these thoughts. These thoughts are not adaptive. And eventually, once you start doing that regularly, you might not think negatively anymore about a specific thing. On the other hand, we also don't want somebody to not feel anxiety at all when we're doing the work. Because if they don't feel anxiety, we can't have them practice their skills. Right? If somebody's really anxious about, if you watch the agoraphobia video with the lady who's fearful of getting on elevators, if she experienced no anxiety at all, we wouldn't be able to teach her the skills that she needs to bring that anxiety down. So no one, if somebody is on meds and they feel really great all the time, then there's no need to do any work. However, the problem is they can't stay on the meds long term because eventually they're going to need more because they're going to build up a tolerance and those meds might stop being as effective. Also, it's probably not healthy for your body, your kidneys and liver, to have to process all of that medication. So we teach the skills to help them help themselves. For the two scenarios that I gave you earlier with Jesse and myself, if you haven't thought about it yet, pause the video and think about your answer. Then you can highlight everything and change the font to reveal the answers. You can pause now and look away. With Jessie, there were several indicators that she might have a diagnosable mental disorder. In her case, she had specific phobia, blood injection injury type. A typical adult might get a bit anxious, body tenses, heart rate goes up, maybe get a little weak, but we can usually talk ourselves through that minute or two and be okay after it's finished, after we get our blood drawn. That fear is understandable because we don't know how good this person's skills are. They might hurt us, stick the needle in too deep. They might stick us in the wrong place, can't find a vein, and have to stick us multiple times. However, we can usually power through that fear in some way, right? Because we know we're going to walk out of this clinic in one piece. It's going to be over in a couple of minutes. Yeah, we might be freaked out. I've had somebody poke me really deep one time. I think she was training, and I bled for hours. With this scenario, there's no DSM disorder. So even though I was in some distress, that distress I was experiencing wasn't out of proportion to the actual danger. It was in proportion. There was no danger occurring. And I also didn't attempt to avoid it. So I was willing to get on that bridge. And of course, my responses, my physiological responses weren't typical. But because I didn't attempt to avoid, because I will still go on roller coasters and take the elevator, go on the second floor, I'll still look down, I'll still take flights. There is no actual disorder, but it's not enough to be considered a disorder. Because after the stimulus, I go back to normal. what's also required for a diagnosis is that it has to really impact my daily functioning in some way. You know, it has to affect me socially, at work, or at school, or some really important areas of my life. And these don't really affect me that much. I just get a little scared, but I push myself through it. With Jessie, this is a huge problem, right? Because is she actually going to die from getting an injection? No. So her response was like, she might be losing something very significant, or something really bad is going to happen to her. And so, because getting your blood drawn is a necessary health maintenance measure, it would probably be very detrimental if she continues to avoid doctors or avoid getting her blood drawn, right? She does have to go to the doctor. She has to get her blood tested from time to time to stay healthy. But had I not gone with her, she wouldn't have gone. So she would have continued to go years if I didn't drag her to the clinic. It turns out she did find some things out from getting her blood drawn, which made her even more apprehensive about getting her blood drawn again. Okay, that's all for this chapter. Talk to you later.